All right, so we're going to be going over the neurological system. Some of it will be a review, and then some of it's the stuff that you're learning in class. So we want to understand the intracranial realm. We have intracranial pressure, pressure. It's made up of brain tissue, blood, and cerebral spinal fluid. Should be about 5 to 15 pressure. Over 20 is abnormal. Remember those numbers. Autoregulation inside the brain can determine blood flow according to metabolic needs. So let's say like you're exercising and when you're exercising the heart and the brain and like they need the most oxygen and blood. And so it can send more blood to the brain. Or if it doesn't need as much metabolically during a certain time, it can divert the blood so that it's not receiving as much. Okay. Cerebral perfusion pressure, so CPP, is the pressure needed for blood to flow to the brain, essentially. So this calculation right here, you need to know this. You take your MAP minus your ICP to equal your CPP. And 60 to 100 is around normal, okay? So increased intracranial pressure. Complications from this, meaning you have decreased CPP, so the blood is not reaching the brain. There's not enough pressure to send it to the brain. Increased risk of brain infarction or stroke, ischemia. And there's a poor prognosis for increased ICP. Signs and symptoms include decreased level of consciousness, vital sign changes, motor decline, headache, and vomiting. And the crazy thing about that is a lot of these things it works sort of in a cycle. So it causes you to vomit because of your increased ICP. Vomiting in turn increases your ICP. And so it's just this dangerous cycle that you get into. A major complication would be decreased perfusion causing cerebral herniation. So, cerebral herniation is when brain tissue moves from one part of the brain to another adjacent part of the brain. Very poor prognosis for recovery after that. A lot of times it happens with the brain stem affecting autonomic regulation of breathing, heart rate, and all that stuff, which is essentially a death sentence. Some risks that put you at risk for increased ICP, mass or cerebral edema from like a hemorrhage, stroke, tumor, infection, or traumatic brain injury. The monitoring gold standard is a ventriculostomy. So they put a shunt in essentially, and then there's like cords hooked up to monitors, and it's used to monitor ICP, and it's also used to drain cerebral spinal fluid to regulate the pressures. And so we're going to be doing a couple assessments to monitor this patient with increased ICP. First is obviously ABCs, because ABCs determine the function of the brainstem and determine whether or not there's been herniation taking place. Two, we want to do Glasgow coma scale and level of consciousness checks. And we're also going to do PERLA because that also tells us the status of the brain, and motor sensory checks as well for herniation. Treatment, we want to decrease the metabolic demand. So if there's increased work of breathing, fever, pain, they're vomiting, we want to decrease all of those so that their brain has a chance to rest. Maintain a patent airway. So the head of the bed is about 30 degrees, no higher than that, because higher gravity pushes down. Same thing laying flat. Hypertonic fluids with mannitol. So we'll talk a little bit more about this, but hypertonic fluids like 3% normal saline or 5% dextrose with normal saline. They're meant to, they pull fluids out of the cells and cause the cells to shrink. And as they shrink, they take up less space in the brain, therefore decreasing intracranial pressure. And then the mannitol is used to it's a diuretic used to just take the fluid off. So you take fluid out of the cells and then drain it. We want to decrease immobility injury, so they're going to be bed bound because we don't want them walking around with a brain injury or increased ICP. So making sure we turn them and do everything necessary to decrease the risk of pressure injury. Decreased risk of injury with seizure precaution. So padded side rail, suction at the head of the bed, oxygen nearby. So alkalosis will sometimes be induced by causing hyperventilation because alkalosis causes vasoconstriction. And as the vessels get smaller, it takes up less space, therefore decreasing ICP. We want a warm room. We don't want them shivering. And then a lot of times they'll be sedated with propofol, midazolam, or phenytoin, just to give the brain a chance to rest. because being awake and receiving that constant stimulation can like further increase ICP. The goal, we don't want to cause any secondary injury to this patient. So by doing all of these things, we're preventing secondary injury. Okay, this should look sort of familiar, like hemodynamic monitoring. We have our ventriculostomy here. There's our stopcock, and then we just need to make sure it is zeroed. So they can be placed up to 30 degrees, but yeah, there's like a port here where you can take out fluid. There's our clamps, and then this is just the machine that the monitors, like a little ball will go up and monitor the amount of pressure. Okay. Cushing's triad, it is refers to a set of signs that are indicative of increased intracranial pressure. So it's bradycardia, irregular respiration, so Cheyne-Stokes, like the really slow, deep, like irregular breaths, and a widened pulse pressure, meaning a high systolic and a low diastolic blood pressure. So like 140 over 32. I don't know, that's an exaggerated example, but that is a widened pulse pressure. Because to find pulse pressure, you take systolic minus diastolic to equal pulse pressure. So more treatments for high ICP. So we want to prevent these 5 H's. So hypoxemia or hypoxemia. So we give them oxygen so they don't get low oxygen. Hypo or hyperthermia. We want to keep their body temperature regulated. Hypo or hyperglycemia. So we're checking their blood sugars. And hypercapnia. So too much CO2. We're not using an NG tube because that can cause further brain injury. You use an OG tube instead, or gastric. And then sedation, like we just talked about, decreases oxygen need in the brain. My husband's playing video games in the living room. It's probably, anyways, that's the sirens. This is a Glasgow coma scale. Just so you know, 10 is the max that someone can receive as a score if they are ventilated because they cannot speak. And then if it's 8 or less, they're in a coma, essentially. 3 or less, they're basically dead. Okay, so just know this and like the scores for that. Head injury, we can have scalp lacerations. Those bleed a ton. So oftentimes it looks worse than it is when you have a scalp laceration because the scalp has a lot of vessels. Skull fractures, they can cause infection, a hematoma, so blood builds up, brain tissue damage. So there's different types of damages. We have diffuse or generalized, just like a concussion, your brain shakes and gets injured, or a focal localized, so a contusion or a hematoma from maybe getting smacked in the head with a baseball bat. It can be in the epidural space, subdural, or intracerebral. You want to find the area of the brain that's affected. A burr hole will help drain or relieve the pressure where an epidural hematoma sits. Okay, and that's when they just drill a hole. A minor injury, they're going to have a GCS of 13 to 15, like a concussion. It just disrupts the neural activity, changes level of consciousness a little bit. Moderate, about 9 to 12, severe, 3 to 8. CT scan is what's going to be prescribed to help diagnose what's going on. There's times where you're going to do PERLA and you're going to see one blown pupil. That means there's brain damage on the opposite side of the brain, like a bleed or something like that. If they're both dilated and non-reactive, meaning they're fixed, there's something wrong with probably the brain stem. And then if they're like pinpoint, it might be because of like an overdose on drugs. To determine if cerebral spinal fluid is leaking, this is really important to know. Common sites you'll see drainage coming from our nostrils or ears. You want to use a gauze, and then this picture shows what that cerebral spinal fluid will look like. It creates this yellow halo around the circle of blood. This may indicate a basilar skull fracture. Other signs could be raccoon eyes, so deep purple under the eyes, and bruises behind the ears. Like this. Battle sign is the bruise behind the ears and raccoon eyes. This is the eardrum of a potential bleed, a basilar skull bleed as well, or fracture. Usually eardrums are pearly gray. This one is deep purple, reddish, indicates there's bleeding in the brain. Okay, brain tumors can be on the brain or spinal cord called meningiomas or gliomas. They're fatal unless treated because you can imagine they keep growing and cause like whatever part of the brain to stop functioning well. Signs and symptoms like persistent, really intense headaches or seizures can also cause problems by pushing on the pituitary gland, causing like SIADH or abnormal release or non-releasing of hormones. You can get cranial surgery to remove it, like a craniotomy, where they take a part of the skull out so they can remove the tumor. After surgery, the goal is to prevent increased ICP. We need to keep everything as low as possible, I mean, in the range, so that they don't have further complications or secondary injury. Some inflammatory conditions, we can have a brain abscess, so pus in the brain tissue. This can come from an ear, tooth, or sinus infection that is untreated. And so it's really important to get those treated because those infections can spread to the brain and cause an abscess that could potentially be fatal. Bacterial meningitis is one that will pop up a lot on HESI, both in maternal and adult health. This is a medical emergency. As soon as you find out that somebody could potentially have bacterial meningitis, you need to isolate them in an airborne precaution room. Okay, this is very contagious. Bacterial meningitis is like way worse than viral meningitis. Viral, you sort of just, it's self-limiting. You just treat the symptoms and wait for it to go away. Bacterial meningitis, the people most at risk is college students because of dorm settings and just high amounts of people in one area. Signs and symptoms include fever, severe headache, nausea, vomiting, and nuchal rigidity. And the way to test for nuchal rigidity is like you can bend their head forward and their like knees will pop up, or if you bend their knee forward up towards their chest, their head will go down. And that's called the Kernig and Brudzinski signs. Okay, so a complication from this is increased ICP for all the reasons we talked about in the last slides. To diagnose it, you can do a CT scan, blood culture, but the lumbar puncture is going to be pretty definitive. The lumbar puncture will be absent of like glucose because the bacteria lives on glucose, so they ate it all. It'll also appear cloudy instead of being able to like read it through, like read a newspaper through the fluid, you know. You can assist the doctor with the puncture. You're going to assist them by putting the patient in like the fetal position essentially. And you're going to, there's like about 4 or 5 vials, and you're going to hand them each vial labeled like 1, 2, 3, 4, 5 in order, because obviously the first 2 are probably going to have blood in it because of the initial puncture, but 3 through 5 should not have blood in it. Having blood in your CSF is a bad sign. Okay. If they have high ICP, this is really important. Lumbar punctures are completely contraindicated because pulling pressure off the spine, like pulling pressure, like pulling CSF off, increases the risk of brainstem herniation, which would decrease your autonomic functions like heart rate and breathing. So just be sure to remember that. Okay. Encephalitis is an infection or inflammation in like the brain tissue. It's usually from a virus that comes from like ticks or mosquitoes. Basically, any CNS and abnormality can present with encephalitis. Treatment would be dexamethasone to increase that inflammation, acyclovir, which is a viral medication, and anti-seizure medications. Definitely want to watch the kidneys by monitoring urine output, because a lot of the drugs that you get to treat encephalitis are nephrotoxic as well. Excuse me. So, okay. Yeah, Brudzinski's is the neck. When you pull the neck up, the knees come up. Kernig's, you pull the knee up and then the head will come up. Or sorry, the Kernig's is you're unable to extend the leg when the thigh is flexed without extreme pain. Okay, stroke treatment. If it is a thrombotic stroke, you are going, like TPA is a clot buster via IV to reestablish blood flow within 3 to 4.5 hours of onset. It doesn't do much after 4.5 hours. So time is of the essence when stroke signs are noticed. So that acronym be fast, balance, eye double vision, face drooping, arm weakness, like you have them hold their arms out and they can't hold one up, slurred speech, and then time. Within 3 hours, they should be in that hospital. Side effects of TPA can be massive bleeding. Obviously, if they have hemorrhagic stroke, they're bleeding, and that's why they're having all these stroke symptoms. We do not want to give TPA. And so TPA is not given until we determine what kind of stroke it is, with maybe a CT scan or something like that. There are absolute contraindications and relative contraindications. Absolute would be like a recent surgery. They're already bleeding, like they have a subdural hematoma somewhere. Those are they're not getting TPA. Okay. And then just remember there's a national stroke assessment. You do have to be like, I think, certified when you become a nurse, to be like know how to do the national stroke assessment or something, I think. Yeah, I don't know. Maybe I'm thinking of something different, but it's just that big paper that you fill out about stroke symptoms and assessments over time. So this right here. Okay. So this is review. I think going back to like physical assessment, but just remember the mini cog test. It's like for dementia, you have a clock face and they're supposed to draw the numbers ends of the clock. It can also be for like if they have like one side of their brain is affected, they're only going to draw the clock on the opposite side, or like, yeah, it's like flipped. So then you know, like they're having problems with one half of their brain. 3-word recall, you give them like cat, dog, bird at the beginning, and then 5 minutes later, after they do the clock, you ask them to recall the words that you said in the beginning. Delirium is temporary. So if you fix the cause of the delirium, their memory and normal attitude will come back. Delirium is often caused by stays in the ICU. For neuro patients, it's very common they would be in the ICU, so that would be a cause of delirium. Dementia is permanent and progressive, and so the most common cause is Alzheimer's. A sign of dementia can be like changes in something that hasn't changed before, like something that's been the same for a long time, like handwriting. Then we have our different types of aphasias. So Broca's aphasia is expressive, so being able to say words, they understand what you're saying, they just can't respond back. This is in the frontal lobe. Wernicke's is receptive, so they can speak words, but they don't understand what you're saying. And that is in the left temporal lobe. Okay. Multiple sclerosis is demyelination of the CNS. Okay, so the myelin of the nerves are sclerosing, it's hardening, so the transmission from nerve to nerve in the muscle system and the CNS is just not working very well. This is something I remember, it might have been from a Hesse book, but instruct them to exercise and stop just before the point of exhaustion. I don't know exactly the reasoning for that, but multiple sclerosis can affect the vision, so make sure to orient these patients to their surroundings, maintain routine, and try and increase their independence. Myasthenia gravis is an autoimmune disorder causing decreased impulse to voluntary muscle. So you can get a myasthenia crisis. So when they're under medicated, their symptoms become worse. Or a cholinergic crisis. They're over medicated with their cholinergic medications, they're anticholinergics, and they get cramps, twitches, GI problems. So a test to determine which one they're experiencing is the edrophonium or tensilin test. You give them a medication. If they have a positive response, it's a myasthenia crisis, give them their regular meds. If they have a negative response, it's a cholinergic crisis, give anticholinergics. Okay. Parkinson's, there is something wrong with the basal ganglia. They have decreased dopamine levels in the body. So to increase those levels, we have carbidopa levodopa, which crosses that blood-brain barrier. Some signs and symptoms you'll see is like pill rolling motion of their hands, a mask-like expression. They're very rigid. They have a shuffle walk and they stoop when they walk. Something really important is obviously we want to assess their swallow reflex for safety when feeding or taking medicine. ALS or Lou Gehrig syndrome is when the brainstem and spinal cord motor neurons degenerate. It's fatal. The only thing is to try and like put off like mortality as long as possible. Huntington's is an autosomal dominant disorder, so it's genetic. When trying to have children, genetic counseling is a good idea if this runs in your family because it is dominant. They'll experience chorea, which is jerky involuntary movements. Guillain-Barré, this is interesting because I've actually seen like 3 people thus far who have had Guillain-Barré at ERMAC, which I thought it was like rare, but I don't know. So this is weakness and sort of paralysis, tingliness, starting from the toes going up. And it becomes a real problem if it reaches the diaphragm, like lungs, airway, because then they can stop breathing on their own. But maximum weakness occurs about 4 weeks, and then after that, you should start to see them getting better. Recovery for everybody is different. The people I know at Ermac who I was taking care of during my capstone have been there since August, both of them. So it's quite a long time. We're also monitoring heart rhythms because like if it reaches that level, lungs and heart are super connected. Okay, so peripheral nerve stimulant placement. So like they might put a nerve stimulator to decrease pain, like a TENS unit, done by ultrasound to find the right spot to put it to treat chronic pain. Headaches, you can have a tension migraine or cluster headache. A tension is bilateral and a tightening feeling. Migraine, you might get an aura. So like aura, you'll feel like sort of dizzy beforehand. You might see spots. It can be unilateral or bilateral. And then a cluster headache is the worst of them all. It's super, super severe pain. And then seizures. Status epilepticus is a seizure that lasts more than 5 minutes. So that's why it's really important to time each seizure witnessed and to instruct patients or their family members to do it for them as well, because they need to call 911 if it's over 5 minutes. A generalized seizure, both sides of the brain are causing the seizure. A tonic-clonic, they'll lose consciousness, fall, become rigid, and then shake. And then afterwards, you'll usually experience something called like a postictal phase where they'll be really tired. They won't come to for a while. So you just monitor them, make sure their airway's clear and all that stuff. You might have absence seizures, which they just sort of have a blank expression. This most common in children, and they usually phase out of it as they grow up. Focal is just one area of the brain. It could be awareness, again, sort of like phasing out. Impaired awareness or motor seizure. So one part of their body starts shaking, but they're aware the whole time. So just different types. Seizure precautions, stay with the patient, padded side rails, make sure the head's protected, they're lying flat, or sorry, on their side. Nothing in their mouth, no like bite blocks, no tongue depressors. Don't put your hands in their mouth. Wait until they're done seizing to start suctioning, unless like you can get some of the stuff on the outside. Obviously, apply oxygen after if you can't. Well, yeah, apply oxygen and then give medication to stop further seizures if directed and ordered. Just a reminder of some reflexes. We have the rooting, so stroke the cheek, turn towards the source, and that's help infants feed. Finding the nipple. Moro is a startle with a loud noise. So it's also known as the startle reflex. Walking, young infants, you put them on a flat surface, their feet will start to move like they're stepping. Grasp, you put an item and they'll hold it. Tonic neck, if you stroke one side of their spine, their head will turn that direction, their leg and arm will go out. The riding reflex, if you place them in like a bad place, like or you put a blanket on their face, they're going to try and correct it. And that's just a safety reflex. Tongue thrust, if you touch the lip, the tongue goes out, and this helps prevent aspiration while feeding. Withdrawal, if they feel pain, they'll move away. Just that's one that never goes away. Ortolani, this is not necessarily a reflex, this is something abnormal. But if you like bend their hips or bend their knees towards their abdomen and then move their legs out like a frog position and you hear like a click, it might mean hip displacement. Babinski is when you stroke the foot and the toes fan out. If this happens in an adult, this is not normal. So something is wrong neurologically. So that's an important one to remember. Then Denver 2 is just a test done to determine developmental milestones at like pediatric appointments. Okay. So practice questions. Having a tonic-clonic seizure, what should the nurse do first? And then D, take measures to prevent injury. We want safety first, right? So C, we're never going to place anything in their mouth. We're never going to restrain a seizing patient. And then A, we don't want to elevate the head of the bed. We want the bed flat and them turned on their side. Okay. So when it has Guillain-Barré, affecting the respiratory muscles requires ventilation. When they ask about the paralysis, how should the nurse respond? The answer is D, you'll first regain use of your legs and then your arms. Okay, that's just the way that weakness starts from the toes up and then it returns the same way. Okay. And so C, Guillain-Barré is not permanent, so we're not going to tell them it's permanent. B, you'll have to accept the fact, yep, again, permanently paralyzed, not the case. A, you might have difficulty believing this, but the paralysis is caused by this disease is temporary. It is temporary, but you wouldn't say you might have difficulty believing this. It's not therapeutic. Okay. Female client with a suspected brain tumor has a CT. What should the nurse do to prepare this client? The answer is B, determine if they're allergic to iodine, contrast dyes, or shellfish. CT scans will usually have contrast with them, and these allergens are typically identified as they'll have an interaction or an adverse reaction to the contrast dye used. You also, for a CT scan, want to check if they're a diabetic patient, if they're taking metformin, because this also interacts with the contrast dye and determines, and like you want to know GFR and creatinine clearance or whatever from the kidneys to make sure that they're able to get the contrast dye out of their system once it's in there. Okay. Okay, they have suspected increased ICP. Respiratory goal is to promote carbon dioxide elimination. This is basically alkalosis, right? The more CO2 that's like expelled, the more alkalytic the blood will be, which can constrict the vessels and decrease ICP. Prevent respiratory alkalosis. Well, no, that's what we're trying to obtain. B, lower arterial pH. Well, that's acidosis. Acidosis dilates. We don't want that because that takes up more space. D, maintain partial pressure of oxygen, PaO2 above 80. I mean, yeah, but not really. Like, I don't know. I don't have a good explanation for that one, but the answer is C. So it's the best, most appropriate goal. Okay. Witnesses a neighbor's husband fall off the roof, rushes to the victim and determines the need to open his airway. The best maneuver to do would be C, the jaw thrust maneuver, just thrusting the jaw forward. The head tilt chin lift is used if a head injury is not suspected, but they just fell off the roof. They might have like severed their spine or hurt their head. We don't want to like start maneuvering their head all around. So we don't do that. And same thing, modified head. No, we're just going to do jaw thrust. And that's that right here. So you thrust here and then pull open the jaw that way. So essentially you're just taking it and thrusting it forward. Okay. Okay, male client having a lumbar puncture, what position should the nurse place them in? The answer is D, side lying with the legs pulled up and head bent down to chest. This is essentially the fetal position. That's to open the spine like these. This is like the bones, like your vertebrae. And then when you do the fetal position, they open like that. And then there's like access to that spinal cord. Okay. This is the same thing for epidurals. They get an epidural. Okay. Okay, positioning with increased intracranial pressure, which of the following positions should the nurse avoid? And the answer is B, head turned to the side, like that. We want head midline and neck in neutral position and head of the bed elevated to 30 to 45 degrees. Ideally, no more than 30. Okay. Okay, clear fluid leaking from the nose following a basilar skull fracture. Assesses this as cerebral fluid if they D, separates the concentric rings and tests positive of glucose. Okay, cerebral spinal fluid does have glucose in it. Okay, so yeah, this is the halo test. Okay, so they had a stroke, they have residual dysphagia. What diet order is initiated? When a diet order is initiated, the nurse avoids which of the following? The answer is A, giving thin liquids. Thin liquids increases the risk of aspiration, so liquids should be thickened. If you remember back in first semester in lab, they had that big jar called thicket. They had you try juice with some of that thicket added. It's just to prevent aspiration. Okay. And then the rest of it is indicated for a client with dysphagia or difficulty swallowing. Okay, trying to communicate with a client with a stroke and aphasia. Which of the following actions by the nurse would be least helpful to the client? And the answer is C, completing the sentences the client cannot finish. We don't want to complete their sentences, and we want to give them time and be patient so that they're able to finish their sentences to help with their healing. A is appropriate, B is appropriate, and D is also appropriate. Okay. Female client has experienced an episode of myasthenic crisis, so they were under medicated. The nurse would assume whether the client has precipitating factors such as, okay, so C, omitting doses of medication. B, taking excess medication would cause a cholinergic crisis. Yeah. Okay, a head injury 6 years ago. Which statement by the parents indicates additional teaching is needing? So basically, what answer choice is wrong? The answer is 3. We will provide for uninterrupted sleep when, oh, sorry, 6 years ago, did I say that? 6 hours ago, they had a head injury. And the parents are asking if they should provide uninterrupted sleep. As much as you want the client to rest, you also do need to wake the child up to assess neurological function. And so unfortunately, like you will need to wake the child up at least every 1 to 2 hours to make sure like their Glasgow coma scale score is appropriate. One, we will call the doctor immediately if vomiting occurs. You don't necessarily, like you should call the doctor immediately if vomiting occurs because it can increase intracranial pressure and indicate that something else is worsening. B, we won't give anything stronger than Tylenol for headache. Yes, narcotics are avoided with head injuries because it can alter the neurological status of a patient. So the Glasgow coma scale is somebody who just took like an opioid might be lower than it actually is because opioids make you more sleepy, make you sluggish to respond, stuff like that. And 4, we know continued amnesia regarding the events is expected. Yes, amnesia can happen with head injuries. Okay, so the wrong answer, but right in this case, is 3. Okay. Yeah, myasthenia gravis, they've become increasingly weaker since the earlier assessment. The physician prepares to identify whether they react to an overdose of medication or an increasing severity of the disease. An injection of edrophonium tensilin is administered, which of the following indicates the client is in cholinergic crisis. And it would be B, negative result, so temporary worsening of the condition. Okay. Improvement of the client's weakness would mean they are in a myasthenic crisis. Okay. They're admitted to the Neuro ICU following a craniotomy. The nurse and medical staff have established a goal to maintain the client's ICP within normal range, which is about 5 to 15. Which of the following should the nurse do? Select all that apply. 1 is correct. Assure the head of the bed is elevated 15 to 30 degrees. Encourage the client to cough and breathe deeply often. Usually this would be a great answer, but with someone with increased ICP, that can actually increase abdominal pressure can also increase ICP. So we want to avoid that. C, monitor GCS, great. Notify healthcare provider if ICP is greater than 20, right? That's a dangerous level. Then 5, stimulate with active range of motion. This also increases ICP. So a lot of things that you would do for other patients, like respiratory patients or bedbound patients, are things that like you're not necessarily going to do for an increased ICP patient. You just have to determine if it's like going to increase the pressure in their brain enough, you know? Okay, so the nurse in primary care, oh, well, answer this and we'll move on. Okay, they're assessing several patients today. Which patient is most at risk for stroke? The answer is D, 72-year-old male. So men are at a higher risk than women. They have hypertension, huge, huge risk factor. Diabetes, another huge risk factor. And they smoke tobacco. There you go. Tobacco is like also a huge indicator. And they're over 65 years old. Another one you might be tempted to pick, a 42-year-old female, less than male, 42, they're not over 65 yet, but they do take oral contraceptives and they have a migraine. Oral contraceptives increase the risk for blood clots, which can then move up and become like stroke. They can cause an infarction in the brain. So they do have a risk factor, but the most risk factors lie with D. Okay. All right. They have subarachnoid hemorrhage, so they're bleeding. They have severe headache, nuchal rigidity, and projectile vomiting. The nurse knows lumbar puncture would be contraindicated because of what? And the answer is 2, increased ICP. So all of this takes them out of getting a lumbar puncture because that could cause herniation of the brainstem. Okay, and that is it for neuro. Hope you learned something.